Hello, my name is Eric Christensen. I am a research director at the Harvey L. Neiman Health Policy Institute. I'm delighted to speak with you today about a study my colleagues and I have conducted regarding use disparities in colorectal cancer screening. The U.S. Preventative Services Task Force recommends an array of screening strategies for colorectal cancer. Foremost among these is colonoscopy, as it has the highest detection sensitivity and is the only strategy that allows for lesion biopsy during the screen. However, some individuals may be reluctant to undergo colonoscopy because of the test's invasiveness, need for anesthesia, and risk of complications. Accordingly, the screening guidelines provide other screening options that do not have the same invasiveness, anesthesia needs, or risk. These options are sigmoidoscopy, fecal or stool-based tests, and CTC colonography, or CTC. While these other screening options do not have equal ability to detect cancer or the ability to do biopsies as colonoscopy, they are helpful to the degree that they are able to expand the population who are screened that would not be screened if colonoscopy was the only option. The law requires that commercial insurers cover all U.S. Preventative Services Task Force preventative screenings. Accordingly, commercial insurers cover all of these screens. However, this requirement does not apply to Medicare, and Medicare does not reimburse for CTC. Given this, we wanted to examine the degree to which use differs for CTC by income. We found substantial income disparities in CTC use. Not surprisingly, those with higher income are more likely to be screened. For colonoscopy, for example, Medicare beneficiaries residing in communities with per capita income of $100,000 or more were 36% more likely than those residing in communities with per capita income less than $25,000. We found similar income use differences for stool-based tests. For CTC, however, we found that Medicare beneficiaries residing in communities of the highest income were 473% more likely than those in the lowest income communities to be screened by CTC. Hence, the relative use differences is many orders of magnitude different for CTC than it is for colonoscopy. This is suggestive of an income disparity, as the presumption is that those with higher income are more able to afford CTC even if Medicare does not cover it. While it is suggestive, it is not conclusive of an income-based disparities, as there may be differences in physical access or patient preferences across the various screening strategies that drive the observed differences. Given that, we also examine the impact of income on the use of diagnostic CTC, which Medicare does cover. Specifically, Medicare beneficiaries residing in the highest income communities were 100% more likely than those in the lowest income communities to have diagnostic CTC. Not surprisingly, there is an income difference, but note that this income difference is also many orders of magnitude less than we observe for screening CTC. From this, we conclude that this difference is associated with reimbursement, given the differences in physical access and patient preferences should be similar between screening and diagnostic CTC. Overall, we conclude that Medicare's non-coverage of CTC may contribute to lower adherence to colorectal cancer screening guidelines for low-income beneficiaries. If Medicare were to provide coverage for CTC, it could reduce income-based disparities for individuals avoiding colonoscopy due to its invasiveness, need for anesthesia, and risk of complications.